Yeah. Good evening, everyone. I don't know whether it's afternoon, good evening, good afternoon, wherever you are, or good morning. We, as part of the session, with the AFRAN research committee sessions that we've had so far. Today we'll be having another session. We have the analyst that I want to introduce. Is one of our great speakers in nephrology across the world. She is Dr. Maitri Shankar. So Dr. Maitri Shankar is a fellow. She's an associate professor of nephrology at the Institute of Nephrourology, Government of Karnataka in Bengaluru. She is a GLOMCOM fellowship instructor and part of the International Society of Nephrology's Emerging Leaders Program, the third cohort, precisely. She serves as the Secretary of Women in Nephrology in India, and that is the Karnataka chapter in India. And then also she was the Program Director of Nephrology Education Collective between 2021 and 2024. Dr. Shankar has received several prestigious honors, including not limited to including the Dr. D.H. Travet Gold Medal and other research nephrology scientist research grants in 2024. The latest she received it was in 2025. That was the Tanker KFRF Young Investigator Award that she received recently, just this year, among all other honors that she received. I will want to leave her to introduce the speaker and then start the conversation. Thank you, Dr. Shankar. Yeah.
Thank you, Dr. Ukam, for the very kind introduction. At the outset, I would like to thank the AFRAN Young Nephrology Committee for inviting me for this wonderful webinar. It is indeed my pleasure to introduce Dr. Grace. Dr. Grace Kansime is adult nephrologist, lecturer, and head of internal medicine department at Mambarara University of Science and Technology in Uganda. She is experienced in clinical medicine and clinical research. Her research interests are in the areas of kidney disease prevention and early diagnosis. Her ongoing projects include a community-based study on hypertension control and kidney disease and tuberculosis. Her goal is the prevention of kidney disease and implementing evidence-based cost-effective interventions for non-communicable diseases in Africa. Her vision is to see everyone in Africa actively looking for African solutions to African problems, which I find is simply amazing. A warm welcome to you, Dr. Grace. Over to you.
Thank you very much, Mitri, and thank you, everyone. Thank you, AFRAN Young Nephrologist, for this opportunity to share my article. And I guess I'll get started. Just a moment. All right, so good morning, good afternoon, good evening, wherever you are. Thank you very much for having me to share this article on behalf of all the co-investigators. So in terms of disclosures, this work was funded from an NIH D43 training grant at Mbarara University, and I have current ongoing funding from Fogat International Center for a Global Health Fellowship. I have also done some consultancy for AstraZeneca Pharmaceuticals. However, for this talk, there is really no conflict of interest. So this is the brief outline for the presentation. I will give a brief background, which is really about kidney disease care in Uganda, which sets the bigger background really for this study. Then I'll go through a few definitions, and then I'll dive into the article discussion and take the questions at the end. So in terms of the background, really, kidney disease care in Uganda. Uganda is a small country in Eastern Africa, and it is a landlocked country. We have currently, I think, about 50 million people. And for the population of 50 million, we have 14 now. The 15th one is coming soon, nephrologists. And looking at this, the prevalence of kidney disease in Uganda is about 6-7% in the general population, but up to 15% in high-risk groups. Of course, when you look at the ISN map, it will tell you about 3%, which, as we know, we really usually have very underdiagnosed CKD. And in terms of offering care for these 14 nephrologists, we actually do have dialysis, and we have 27 dialysis centers at the moment, but as you can see, most of them are located right in one place in the city of Kampala, or within a 5-kilometer radius of each other. And so what that means is that also the nephrologists are located just within 5-kilometer radius of each other. And it is just the two of us that are down here in Mbarara, which is in the western part of Uganda. There are a few dialysis centers in the northern part, which are run by physicians. So which means that the rest of the country, what happens to the patients, your guess is really as good as mine. So that's really Uganda for you. That's kidney care, whether AKI, CKD. We recently started a transplant program. I think we've transplanted 5 people. So that's really kidney disease care in Uganda. So in terms of definitions, we know that acute kidney injury is a sudden decrease in kidney function, which manifests as an increase in serum creatinine, either within 48 hours or 7 days, or a reduction in urine output. And we know the usual stages. This is the KDIGO 2012 definition. And for this study, our definition for acute kidney injury was a sudden decrease in kidney function, which we defined as a 50% relative increase in serum creatinine from an imputed baseline at enrollment, or a 50% relative increase in serum creatinine at D7 compared to day 0 for those not diagnosed with AKI on day 0. So what this means, in our setting, very many of the people from the population, from the community, have never had a creatinine done. And in low and middle income areas, this is what we face every day. Patient comes to you and they are having a creatinine for the first time when they are sick. They have no baseline. So how we defined creatinine, if you had no baseline, we had an imputed baseline for you to make sure that we did not miss AKI at the time of presentation. So that's the first part of the definition. And then for those who had no AKI at presentation, we looked for AKI on day 7. So that is really our definition. So tuberculosis, we know, is associated with significant mortality and morbidity. This is an infectious disease caused by Mycobacterium. We know that it is the leading cause of death as an infectious cause. Currently, well, it is second only to COVID-19. We know what COVID-19 did, but it really stays as the leading cause when you compare with the renowned infectious diseases. HIV, malaria, TB is on top of the list. And it is the 13th leading cause of death generally worldwide. And we have much as, when you compare this with kidney disease, because the prevalence is about 10 million, 10.8 million, as in 2023, that was the incidence, because it is a curable disease. When you compare this with kidney disease, which is 800 or so million people, you think this is nothing. But the biggest thing is that tuberculosis occurs in the whole world, but 87% of tuberculosis actually occurs in high burden countries, which are only 30. And most of these are in Africa and low, middle, and middle income countries. So much as we have this high burden of tuberculosis, Uganda is one of those countries. So its impact on kidney function is not well understood. And even when it was studied before, it was usually attributed to the medications, not the disease itself. And a study that had been done in Korea had shown that the incidence of AKI is between 7 to 10% among people with tuberculosis. So in our study, we aim to assess the incidence of AKI in the immediate post-TB diagnosis period in Uganda, which, as I have already stated, is a high burden TB, but also TB HIV co-infection country. So in terms of methods, this was a prospective observational cohort study of adults with drug-susceptible TB, who we follow up from TB diagnosis to up to 2 years. This is still ongoing until July this year. So these are adults aged 18 years and above with no history of kidney disease. We enrolled them between August 2022 and July 2023, within 7 days of TB diagnosis at 3 regional referral hospitals. So these regional referral hospitals, Mbarara, Kabale, and Masaka, together they serve about 12.5% of the Ugandan population. And our primary outcome of interest was the incidence of KDIGO-defined AKI within 2 weeks of TB diagnosis. So we stayed 2 weeks because we were enrolling them within 1 week and diagnosing AKI within 7 days of enrollment. And in terms of other outcomes, we also looked at predictors of AKI and then its association with 30-day mortality. So in terms of results, who did we include in our study? So in terms of identification, this is how we identified patients whenever they came into the various units. So we did not make the diagnosis of TB. The diagnosis of TB was made as it is made usually in clinical practice. And so we screened our patients or our participants after they already had a diagnosis of TB. And so a total of 345 adults with active TB were screened for enrollment into the study. Several were excluded for these reasons. And at the end of it all, we had 161 participants that were eligible. Of these, almost half, so 78 had HIV or infection, while 83 did not have HIV. We lost 5 participants within 1 week in terms of follow-up. They never returned for the day 7. So we analyzed data for 156 participants. So in terms of baseline characteristics, these are young people, as you can see, with a median age of 39. And those that were HIV positive were slightly older at 40 compared to the HIV negative ones at 32. And males were the majority of this population. In terms of the population with HIV, so like I'd said, almost half, 49% were HIV positive. Of those who were HIV positive, 43% were already on ART. But most of them, almost 70%, had severe immunocompromise with CD4 less than 200. So in terms of symptom duration, on average, participants had been with symptoms of cough, fever, and all that for about 30 days. This was more among people who were HIV negative. They had, on average, had symptoms for about 60 days compared to 21 days for the HIV positive ones. All participants were enrolled within 1 day of TB diagnosis. And in terms of kidney function, the median serum creatinine was 0.86 with an eGFR of 104. But significantly, the eGFR was lower among the group that were HIV positive at 89 compared to 110 for the HIV negative ones. So for our primary outcome of incidence of AKI, the incidence of AKI, the cumulative incidence was 33%. And in this 33%, so 27 or about 16.7% were diagnosed right at enrollment or day one, as they presented in hospital or as we took them for enrollment into the study. And then the rest were diagnosed on day 7. And then in terms of stages, majority had stage 1 and only 5%, almost 6% had stage 3. Well, in terms of the different groups, HIV positive versus HIV negative, this incidence was not different. It was 33 among the HIV positives versus 32 among the HIV negatives. And in terms of predictors of AKI, so for the population who did not have AKI at enrollment, those who developed AKI on day 7, having proteinuria or hematuria at enrollment was associated with higher odds of developing AKI by day 7. So, and in terms of mortality, which was the other outcome, having AKI, whether at enrollment or at day 7, was associated with a significant risk of mortality with adjusted hazard ratios of 7.5. And this was regardless of the HIV status. So whether you were HIV positive or you were HIV negative, having AKI was really significantly associated with death. And having HIV was really not significant. So whether you were HIV positive or negative, your risk of death was increased by AKI. So remember, in our definition of AKI, we had an imputed baseline for patients who did not have, for participants who did not have a baseline and yet had a raised creatinine at day 0. So for this, we used an imputed creatinine, and this imputation, so there are several studies and several methods for imputing baseline creatinine. So we use the one that has been suggested by the Acute Kidney Injury Acute Disease Quality Initiative group. And this is the one which assumes that your EGFR is 75, your baseline EGFR is 75. So you assume that someone's EGFR is 75, then you calculate the creatinine for that EGFR. So as you can see, this is a very conservative equation, particularly in a young population like ours, which we had, because for people who were aged 30, the EGFR is usually actually more than 75, but that's what we used. And so we wanted to be sure that for these participants, it was actually AKI and not CKD. And so we did this to show the trajectory of creatinine for those participants. So if we saw you at day 0 here, and we used an imputed creatinine, and we thought you had AKI, what was your creatinine like at day 7? Because if it is AKI, we are hoping, or we assume, at least from the definition, that your creatinine should be getting better. Or at least if your creatinine is getting better, that's something that confirms to us that indeed at day 0, you had an AKI. And so what happened, as you can see on these two graphs, for those patients, the 16%, the 27 who had AKI at day 0 from an imputed creatinine, 66, almost 67% of them had an improved creatinine by day 7. So you can see the green line. So from an imputed baseline, if your creatinine had gone up by day 7, as you can see for most of them, the lines are coming down, showing that your creatinine was actually coming down, which is at least something that confirms to us that by the time we got you here, you had an AKI. And 7% of these had AKI progression. As you can see, one of them is here, another one is here. So some people had their AKI progressing. 7%, 2 of them had died within that 1 week. So we don't have their results for day 7. And then 5 of them, or 18%, their creatinine was still about the same. So this is why we did these trajectory graphs, to really show that the imputed creatinine was really an AKI for these patients, for these participants. So in conclusion, the incidence of TB-associated AKI in the immediate period after TB diagnosis is high and associated with increased mortality risk, and this is regardless of one's HIV status. So all patients diagnosed with TB should have their kidney function assessed and monitored routinely, irrespective of their HIV status. And you may be here watching and listening in, and you're saying this is what is usually done. Yes, this is what is supposed to be done, but in low resource settings like ours, this is not done. So patients are not not routinely monitored. They come in, get diagnosed with TB, and walk away with that TBs when no one knows what their kidney function is. And so we recommend that future work in this area should focus on longitudinal kidney function, looking at underlying mechanisms for AKI, early mortality predictors to improve outcomes in this patient population. And the reason for this, in our study, as you see, we took in everyone who came, was diagnosed with TB, and even at the start of treatment, because like I said in the introduction, most of the AKI has been thought to be because of medications, but these patients had not yet started medications and yet they had AKI. And so this shows that most of this AKI is actually from other things. Yet in this study, as our limitation, we were not able to show the cause. We were not able, because these are people who are coming from the community, we were not able to show what they had been taking, so nephrotoxic medication, any herbs or anything. But we also think a bit of TB sepsis and volume depression and all those things. We were really not able to show all those. So we think that all these contribute to this TB-associated AKI high incidence that we found. And in terms of HIV not being significant, most studies that have been done, they have shown that there is a lot of AKI in HIV. And actually, as we went to do this study, our hypothesis was that we have more people having AKI among the TB HIV co-infected compared to the HIV negative ones. But we found the opposite. We found actually that HIV was sort of protective in a way, especially for mortality and all. And our thinking is that our HIV care programs right now, for most of us, at least in Uganda, it is test and treat, meaning that once you're tested with HIV, irrespective of your CD4 count, you start on ART. But you also get to be monitored regularly and you're in contact with a health care facility regularly. And so, and they go out of their way, they have high index of suspicion for TB, they go out of their way to screen these people for TB, they even use like very sensitive tests, they use the urine lab even when you don't have signs and symptoms. So what this means is that actually the HIV care program is catching people with TB early. And as we saw between symptom onset and presentation, people with HIV were presenting much earlier, 20 days, compared to people without HIV who were presenting 60 days on average from symptom onset to diagnosis. And so what this means is that without HIV, maybe people's index of suspicion for TB is low, and also patients take long in the community, so maybe they come in with sepsis. So the HIV care system is actually helpful when it comes to this. And so I would like to acknowledge the funders for this study. So the D43 training grant for multi-mobility Uganda Research Capacity Initiative at Imbara University. I would like to acknowledge the study team and participants, all the staff of the TB units at Masaka, Kabale, and Imbara Regional Referral Hospitals, and all the co-investigators. And I would like to, I think my take-home message for each one of us who take care of these patients is really from this editorial that was written by my mentors, that if you are taking care of TB patients, think kidney function when testing for treating tuberculosis. That would really be my take-home message. So I want to thank you all for listening. Thank you, AFRAN Young Nephrologists, for having me share my article. And I believe that if we work together to take care of our patients and all the people that we take care of, and think not just kidneys, but in everything that we do, think about each other and each disease leading to another, we shall have a happy person, but in this case, we shall have happy kidneys, which will give us enough urine. So thank you very much. I will take questions. Oh.
Okay. Thank you, Dr. Grace. Thank you, Dr. Grace, for that excellent presentation. Well, please, for those the participants, you can put up your questions on the chat box. After the analysis, we'll take up that question and answer session. Thank you. We will now allow Dr. Matri to look at it.
Thank you, Dr. Grace, for that wonderful study that you have put in. I'm sure you've all put in too much of hard work. It is very evident. It has been a collaborative study from a low resource setting, which is actually a plus point for all of us and many things to learn. So I've just jotted down some of the strengths of this study. So what I felt were the strong points of this study was that it was a prospective cohort design. So the study followed patients from TB diagnosis through 30-day outcomes. So this minimized recall bias and enabled temporal association, like you aptly told, about TB diagnosis, development of acute kidney injury, and mortality as well. And the second thing which I noticed was the inclusion of both HIV positive and HIV negative patients. So this allows for comparison and generalizability across the spectrum of TB patients in a high burden setting. So this was a real world resource limited setting. So this was conducted across 3 regional referral hospitals in rural Uganda, making the findings highly applicable to other low and middle income countries like India. Early and systemic kidney function assessment, like you rightly pointed out, you gave up, you showed the clear definitions of, KDIGO definitions. The creatinine was measured at TB diagnosis and at day 7 post-enrollment, capturing early AKI events that may have otherwise been missed. The ADQI definitions were used, KDIGO criteria was used. And this study has focused on one of the most neglected areas, that is, it has highlighted the unrecognized clinical complication, that is acute kidney injury in TB patients even before the start of treatment. So which challenges the prevailing assumption that usually AKI is because of anti-tubercular drug treatment. The mortality association analysis, the study robustly linked AKI to 30-day mortality with multivariable adjustment, so underlining the prognostic importance of the study. Identification of simple predictors, that is urine analysis, proteinuria, hematuria, they were found to be significantly associated with acute kidney injury. So these are very practical and low-cost tools for risk stratification, especially in countries like ours. And there was transparent reporting and ethical rigor. The study followed STROBE guidelines, received ethical approval, and involved informed consent, enhancing methodological transparency and ethics. Timely public health insight. So these findings support urgent calls for routine kidney screening in TB programs, potentially influencing guidelines and policies in the middle and low middle income countries. So coming to the clinical relevance of this study, why does this study matter? From what I could understand, acute kidney injury is increasingly recognized in developing countries, especially in infections like tuberculosis. So this study shifts the perspective from drug-induced acute kidney injury to TB-induced acute kidney injury. And the key takeaway that which I found from this study was that 1/3 of the patients with drug-susceptible tuberculosis in Uganda developed acute kidney injury before or shortly after treatment initiation. So this is a much higher incidence than previously appreciated. I think that's correct, right, Dr. Grace? I think this percentage is much more than the previous studies. Dr. Grace is here?
Yes, sorry, I was
Yeah.
just looking at the questions in the chat. Yes, that's very true. And
Yeah.
maybe I will talk briefly about that when you're done.
Yeah. So some points which came to my mind, like you aptly mentioned, the cause for acute kidney injury were not very clear because renal biopsy was not done, which has been one of the limitations in this study. So how can you clearly differentiate whether it is drug-induced acute kidney injury or tuberculosis causing acute kidney injury? Or what do you feel could have been done to differentiate this better in this study? So this was one of my questions to you.
Thank you very much, Mitri. And so maybe to just go backward. So the previous studies, indeed, they had shown a lower incidence of 7 to 10. And I think that one of the main reason for this, they were really excluding people because they were looking for TB really, AKI really caused by TB, either TB or the medication. So they tried and excluded people in whom they thought that AKI was caused by other things, particularly sepsis and volume depletion, which we did not do because in our setting, we took everyone and clinically speaking, in the real world, when you have a patient in front of you, you need to know that they are at risk of AKI with the disease, the TB that they have, with the medications that you're going to start, will they worsen their AKI or not? So looking at our setting where resources are very limited and we don't routinely check the creatinine, I think taking everyone was really good to give us this information and call for improved routine practice. In terms of causes of AKI, so that really goes with the causes. Also, in this study, we included people because we know that TB care is usually outpatient. Patients are only admitted if they have reason for admission, at least for drug-susceptible tuberculosis. So we also included patients who were admitted and those that were outpatient. So in terms of causes, it was really hard to tease out what patients have been on prior to coming to hospital, particularly in a setting where a patient will have gone to 3 or 4 health facilities, but will not come with anything written. They'll say, I bought some medications, I took something. And as you can see, because when someone is sick for 60 days, definitely they will seek care, but they will not know what exactly they were taking. And remember, this is cough, this is fever, so some antibiotic in there, some NSAID in there, we really could not tell. And some maybe herbs when the medicines are not working. It was really hard to tell. In terms of biopsies, yes, I think that starting here is a step in the right direction, that we first get to know that actually there is AKI. Some is due to TB or medication, but there is also this bit that is actually not due to this. And then we can start thinking of biopsies to really find out the underlying cause, because we know that biopsies are really not very easy to do again in our setting. So TB versus drug-induced, we could not also confirm if these patients had urogenital TB. So we did not do any tests, maybe expert on urine. So this would have been good to get to know maybe out of those patients, even without biopsies, to show the lesions for TB in the kidney, how many of those patients actually maybe had positive TB on urine. We also did not do that. Yeah.
So some of the points which I went back and did some literature search to, which would help us differentiate between TB-associated acute kidney injury and anti-TB drug-induced acute kidney injury. So if you look at the timing, the TB-associated AKI is usually at or before initiation of anti-TB therapy. It is like you aptly mentioned, it could be because of sepsis, volume depletion, interstitial nephritis, or it could be TB granulomatous nephritis. And the symptoms could be more of TB, like fever, weight loss, cough, systemic TB symptoms, and urine analysis like proteinuria, sterile pyuria, and hematuria. Serum creatinine is elevated at the diagnosis or within the first 2 to 3 days, because the drug-induced TB might take some time for the creatinine levels to increase. Eosinophilia is rare. That is more common in anti-TB drug-induced AKI. Systemic features like in anti-TB drug-induced AKI, we may have rash, fever, and hepatotoxicity. I think rifampicin is most notorious to be hepatotoxic and cause drug-induced AKI compared to isoniazid and pyrazinamide. Drug rechallenge, of course, again in anti-TB drug-induced AKI. Histology, we've already discussed about that. And management, again, TB treatment, of course, continues in TB-associated AKI, but in anti-TB drug-induced AKI, we stop the drug and we see if it is improving, and then we may even switch over to corticosteroids. The prognosis, definitely, a TB-associated AKI has poor prognosis compared to anti-TB drug-induced AKI, which is usually reversible, and most of the studies have shown very good prognosis after stopping the offending drug. So yeah, so this was that. And the other point was screening of HIV patients for tuberculosis. Is it routinely done in your country? And I feel that it is very important, and most of the countries should adopt this policy of screening all HIV patients for tuberculosis at the time of diagnosis of retropositivity, and also on a regular basis. So what is your comment about this, Dr. Grace? How is it in your country?
So just like I said in Uganda, as long as you're diagnosed with HIV before you're initiated on treatment, you are screened for several opportunistic infections, and TB is one of them. So that you really go up and above and beyond to really make sure you do not have TB. So if you have TB, you start on treatment also to make sure you do not get high risk. So, but then also during care, even for people that have been in care for some time, because we know that TB is that opportunistic infection that doesn't really come when one CD4 is way down. It can come at any time. And so if anyone CD4 maybe goes down, viral load goes up for some reason, or they complain at the first complaint, and they also educate the clients that if you have any cough, even if it is not yet your time for return, please return. And every time the patients come in, they really go up and above to really look for TB. So I think that's very helpful. I think when we looked at the baseline characteristics of people with HIV, they were healthier than the people without HIV. Yeah, so I think that's why.
So HIV infected patients, like you aptly mentioned, they might be having subclinical tuberculosis as well. So once we start the antiretroviral therapy, there is always chances of presentation with symptoms of tuberculosis because of iris, and there is unmasking of the immune reconstitution inflammatory syndrome. So like you aptly mentioned, screening for patients beginning with the therapy for active tuberculosis is very important. And moving on, so one point which caught my eye was that 15 participants had indications for dialysis, but none of them were able to undergo dialysis because of cost and access issues. They were managed conservatively, and 8 of them died, if I'm correct, if I'm right with the numbers, which is actually a very unfortunate scenario. And this is something which we see in our country as well, in India. So this clearly highlights the problems faced in developing nations: lack of resources, lack of funds, lack of infrastructure for kidney replacement therapy. So an ideal scenario would be prevention of acute kidney injury, screening and early diagnosis of kidney dysfunction, which is one of the areas of research interest, that is screening, early diagnosis and prevention of kidney disease. And this, I think, could be done only by empowering the primary care providers like the pharmacists, the ancillary nursing staffs, the dialysis technicians, who can probably screen the patients, the primary healthcare physicians or the family physicians. So they are the ones who could probably screen for acute kidney injury or chronic kidney disease among the population that they are covering. So what is your opinion on this?
So thank you very much. We know that when it comes to equity in care and dialysis. Dialysis has really been relegated. It is something that is not thought about. Yes, we appreciate that dialysis and generally care for end-stage kidney disease is costly to individuals, to government. So in Uganda, the healthcare system is mostly public and subsidized for most of the things. But I usually say, personal opinion, that there is no patient who walks into hospital and goes back home without spending money directly. Because when you see a nephrologist for free because government has paid me and employed me, I will send you for a creatinine test, and if reagents are not available in the laboratory, they will send you outside in town to do that test. Or when you find the reagents on that day and you get a creatinine done, and I write medications, out of the 5 that have been written, maybe 2 will not be available in hospital. And that is the daily situation. And that is on an ordinary level of OPD care. So when we come to dialysis, just like I showed you at the beginning of this presentation, so we have 27 dialysis centers. Of those, only 7 or 6 are actually government, and 2 are in Kampala, 3 are outside Kampala in the north and wherever in the east, and 1 is in Ibarra. So my hospital actually has a dialysis unit, 7 beds, and it has just improved from 2 beds in the past 2 years or so. So we are even happy it has more than doubled. But then the reality is that even when the cost of dialysis is super subsidized, I, as a nephrologist, will not afford dialysis. On my salary, yet I am well paid in like the top 2% of Ugandans. So then it leaves you, and especially knowing that tuberculosis is actually a disease for people with very low socioeconomic status, then it leaves you thinking if they can actually afford dialysis, if they get the complications that get them to need dialysis. So dialysis in Uganda at my hospital, patients pay about $30 US. So they pay 100,000 Ugandan shillings, but that is a lot of per session. But that is a lot of money. That is really a lot of money. And remember, if you're going to be dialyzed for AKI, you maybe have to do 5 consecutive sessions. So that comes to somewhere about 150 money that you're paying to the hospital. This does not involve buying a catheter, which is bought somewhere else in a private pharmacy. So you need about $200 as cash. So most times people have to call home, sell a goat or sell something to be able to mobilize these funds. And so it is no wonder that most patients really with AKI do not get to access dialysis, even when the dialysis unit is right there. Actually, on the same ward, we have a medical ward where one room is really dialysis unit. So even when we say access, it is really usually cost. And so we had 15 participants who had an indication for dialysis. All these were managed conservatively. And maybe I think in talking to this, I'll answer Prof. Valeri's question. She asks if the results were provided in real time to the caring teams of doctors. So yes, for patients that were admitted, every time when we enrolled the patients and took off samples, we provided them with a copy of the results. For those that were in outside hospital, we gave them to the team at the TB unit for when patients would return. So yes, these results were provided. Patients got conservative care, and yeah, those were the results. Thanks.
So moving on, HIV and TB are a deadly complication, as you all know. HIV weakens the immune system. It attacks the CD4 plus T cells, making it difficult to fight off infections like tuberculosis. And tuberculosis is an opportunistic infection. It thrives in individuals with weak immune systems. There is always an increased risk of tuberculosis in people with HIV, having a significantly higher risk of developing active tuberculosis compared to those without HIV. And also, a co-infection of TB and HIV, most of the studies have shown that the mortality rates are higher. HIV exacerbates TB and TB also exacerbates HIV. But here, in your study, we find something novel. It is something new that HIV co-infection was associated with lower odds of mortality. So, what do you think would be the reason for this?
So like just like I said, we think that really what happens, we have had studies of AKI among patients with TB, AKI among patients with HIV. We've shown that there is a lot of AKI among patients with HIV, but compared to the general population. So I think we have not had a study that is having this head-on comparison between HIV positive and HIV negative. And this is what we did here. And I think it just shows that when you will have HIV and you're being taken care of, and just like we know, you have HIV, you're being taken care of, you're as good as any other person in terms of most clinical aspects and outcomes of disease. But we also think that actually having HIV and the HIV care system is having a more positive benefit to the patients in terms of their TB diagnosis because they get diagnosed early. So
Earlier,
so they didn't have most of sepsis and all. So they got to start treatment early before the AKI may be related to sepsis and severe disease.
Okay, so some of the implications of this study for the nephrologist, it has been very useful. The study, some of the clinical implications which I will take back is that TB itself can cause AKI early on, not just the drugs. Early kidney injury may be subclinical. So just the simple markers like proteinuria and hematuria can serve as early markers. Hospitalized TB patients need close renal monitoring because in your studies show that inpatient TB inpatients with tuberculosis had higher risk of acute kidney injury. And some points related to public health. Routine kidney function testing should be part of tuberculosis workup. Whenever someone walks in with a diagnosis of tuberculosis, I think that is the time when we should be checking their creatinine and urine routine. And this also highlights the need for improved acute kidney injury recognition and dialysis access in developing nations, as we just discussed, and opens lots of avenues for studying the mechanisms of tuberculosis associated AKI early on. Suggests HIV positive patients may present earlier, potentially leading to better outcomes, which is something novel and new to learn. So, how do we use your study in our practice? We will definitely consider adding baseline creatinine and urine analysis to all TB admissions. Be vigilant even before anti TB therapy begins. Push for a point of care testing. Like, for example, I just read that in your study, you used point of care urinary lipoarabinomenin in HIV patients to diagnose tuberculosis. So that we have not been able to use I mean, it is not universally available, universally in use in India in our TB program. I think that is one thing which we could implement. It has a very good sensitivity of 88 to 99%, especially in retropositive patients. So this could be just like, it is very simple to use as well, just the urine point of care test. So I think it is a very good resource in for developing nations to identify patients with tuberculosis in HIV. Also, we should push for better resource allocation when it comes to dialysis access and kidney care. So, some questions which I wanted to ask to the group. Should TB programs universally include kidney screening at diagnosis based on this beautiful study by Dr. Grace? I think most of them will say yes to this. Can proteinuria and hematuria be used as low-cost AKI predictors? How do we distinguish between TB-associated AKI and AKI from other causes in LMICs, which is a big question mark, which we discussed with Dr. Grace? And should HIV-positive patients be monitored differently for acute kidney injury compared to other patients, like more frequently? So yeah, that is this is for the group to ponder. Thank you, Dr. Grace. I think over to Dr. Ukam now.
Yeah, thank you, Dr. Matri. I don't think there could have been any other better analyst than Dr. Matri. Thank you so much, Dr. Grace. That was a nice presentation. an excellent presentation, and the analysis was superb from Dr. Matri. We already have some questions, question in the chat, but I think Dr. Grace has done justice to some, but let me just go through. But before I do that, let me recognize Professor Ifeoma Olasi, one of our very own in our International Society of Nephrology, so we cannot just, our hand is up. I think we should give her that opportunity to maybe she has something to say to us. Professor Olasi, please, can you just, yes, thank you.
Thank you very much. I'm very happy to be part of this webinar, and the beautiful presentation you had there, Grace, and the analysis, of course, by Mitri is top-notch. But my comment is this is mainly for nephrologists. And my take is that we should actually have primary care physicians in this forum listening to this, because many of our patients, of such patients with TB, or even our patients with early kidney disease, present to them. So they should know about this, not just us. So do we have them in this webinar? Or do you plan to kind of have some training or some webinars for them? Because the idea of the whole thing is to spread the word so that people get to know that this is what they need to do when they have such a patient. That's my take, but very interesting and good research, wonderful research, and wonderful presentation, and wonderful analysis, and wonderful sharing. Thank you so much.
Thank you, Professor Lassie. Yeah, I think I'm sure it's noted, Janik. I'm sure Janik has noted that, and then Dr. Grace from the other part of Africa, Uganda, and all that. So Janik will look at it. Dr. Professor Lassie, Janik will look at it. Is the co-chair, the chair for subcommittee, research subcommittee, and all that. So I think he has noted that. That's not your concern. Okay, so but we'll look at the chat box, and then Professor Valerie, so I think Dr. Grace has already looked at what has already answered the question from Dr. Valerie, but she says it's a phenomenal, very clear presentation and very well planned and executed study. But she asked that did the clinician get the result in real time, or was all analysis done afterwards? The second question is from anonymous attendee. Do you think the imputation may underestimate acute kidney injury here, given that these ill patients may have lower muscle mass and lower creatinines? Then Valerie also asks, second question, that could one assess acid-fast bacilli in the urine, or do gene expert on urine to assess, or do gene on urine to assess if some of the AKI is related to TB? This will probably take a longer time to resolve. I want to make clarification on that.
Okay.
Another question is, I don't know if we take one by one or just go through all. Another one is from Baha. Baha said, have you measured complement factor in AKI patients? I think we should go with that for now. Then we can.
All right. Thank you very much, Dr. Ukam, and thank you, Mitri. That was excellent. So anonymous attendee about the imputation underestimating AKI. This is very, very true and very likely, and I think I really hinted to that, particularly for the patients, for the participants in whom we diagnosed AKI at enrollment using the imputed creatinine, because like I said, we were using an eGFR of 75, and this is a young population, and I didn't show that, but we had like less than 4% people had diabetes, less than 10% had hypertension. So this is a young population without risk factors for chronic kidney disease. And so what that means, assuming that their baseline eGFR is 75 is really an underestimate. So what that means is that we could have underestimated AKI, and indeed the literature says that all the reviewers about the different imputation equations mention that, and this is the downside of using that imputation. It is always the best that if there is a measured baseline creatinine is what you use, but unfortunately we did not have. And those are the realities, I guess, that we face practicing wherever we practice, because even when patients have been in care, for example, in HIV care for years, you will find that they have never had a creatinine done. So even then you will not have a creatinine. So it is likely, and yes, in addition, because we know when patients have TB, they tend to lose weight, and indeed their baseline BMI for most, I think more than 30%, they were underweight. So that is also possible because, again, we are using creatinine, but this is more in the HIV negative people, actually. The HIV positive people, because they were diagnosed early, again, tended to have normal BMI. So Prof. Valerie, in terms of diagnosing TB in urine, yeah, so we could do AFBs, the catch, the sensitivity is very, very low, and equally for Gene Expert. We had, as part of this, we actually did store urine samples. So some of these things maybe we may do later as we get resources and funds. We may do some of this to show maybe what percentage of what proportion of the people actually had maybe some positive TB in their urine. These are all possible because I guess because that in the TB world, because usually the sputum solves lots of things. And now in HIV positive people, we tend to use urine lamp because the expert can be negative because they are not shedding if they are severely immunocompromised. So urine is usually a sample that they don't use for the regular tests. Dr. Baha, you asked if we had measured complement factor in AKI patients. So in this study, unfortunately, we did not, and routinely we do not do this. So no.
We still have, though they are, I think it's a part of telling you, Valerie is saying excellent moderation and presentation by Matri. So Matri, Valerie is saying thank you. Exemplary, that is quite an exemplary webinar. Congratulations from Valerie.
Thank you, Valerie. Thank you so much. Thanks for attending.
Yeah. And Lugwama Conrad is saying this was very educative. Thank you for the presentation, Dr. Grace, especially for you. Especially for Dr. Grace, that is an excellent presentation.
Thank you very much.
All right. Yeah, but Dr. Grace, there is another question. I said, congratulations, Dr. Grace, for your very nice presentation. Most of the patients had stage 1 AKI, which rapidly regressed by day 7. Could dehydration be one of the causes? Did you assess this? Why did you limit yourself to creatinine measurement and did not take into account the third day after inclusion?
Okay, so thank you very much. Whoever has asked a question. So I guess one of the things usually that limits what we do when it is not routine practice is the funds. But also remember we had participants that were coming from home. So we tried to follow the KDIGO definition for AKI. So why didn't we do a creatinine at 48 hours? That was mostly because it meant we had to call people from wherever within 2 days of diagnosis, which was really out of reach for the study. So that's why we opted for the 7-day one. Remember that in TB care, patients usually don't come back for review at day 7. They come at least 2 weeks later. So this was specifically for the study. But prior to, so because remember I said this is a prospective cohort. So we saw these participants again at 3 months, so 90 days, at 6 months, at 1 year, and then at 24 months. So we are yet to analyze that data and found what happened, particularly for the 90-day one, to see who resolved, who got better. So maybe at some point in future, we shall be discussing that. And yes, I agree with you. And just like we said, one of the causes of the AKI, true, could be dehydration and volume depletion due to TB, sepsis and all. So I totally agree. And it is also nice to see that most of this AKI is stage 1 and hopefully it can resolve. But that's again the reason for monitoring, because like we showed in the trajectory, for most people, 67% of the people who had AKI at day 0, the creatinine had gone down by day 7, even if it had not resolved, but at least it had gone down. So that is very good for our setting, that once you have this patient at diagnosis and they have an AKI, you intervene so that you don't give them drugs and all that are going to make the AKI worse. Or when you start the treatment, then you monitor them to make sure that actually the treatment, just like Mitri said, is not making the AKI worse. So that is the whole thing. You either detect the AKI early, or you prevent it, or you prevent it from worsening. So that's really the whole thing of routine and recurrent measures. Yeah, so that's the hope. Thank you.
Yeah, that's great. Samuel is also telling you that it's great presentation. Well done, Dr. Grace. And Professor Lassie is congratulating all of us, the presenter, the analyst, and the moderator. So we appreciate you, Prof. We appreciate you for that. Then Professor, I just want to tell Professor Lassie that Dr. Yannick has accepted that he will consider the proposal for the next time to extend this kind of webinar to general practitioners. So the next other series will definitely bring up the general practitioners. All right. So on this note, I want to thank special thanks to Dr. Grace. I want to thank Dr. Grace for accepting to be our speaker for this session, for this series. Thank you so much, Dr. Grace.
Thank you very much for having me and for listening to my presentation. And Professor Ulazi, thank you very much. We try by all means to really spread this gospel to the non-nephrologists, true, because they are the ones that see the big chunk of these patients, really. So, yeah.
I also want to thank Dr. Matri Shankar for accepting to analyze the article despite her busy schedule.
Thank you. Thank you so much. Yeah, thank you so much for having me. It was really educative, and congratulations to Dr. Grace for this wonderful study, and Dr. Yannick, Dr. Ukam, and the AFRAN Association for having me. Thank you so much.
I also special thanks to AFRAN ESCOM for the support. But we want to most especially thank all our participants. Very, very dear to us. I want to say thank you all for participating in this series. We are very, very happy, and we are happy that for your questions, and the next series shall be better. We shall do better, and we'll improve on this, whatever concerns that must have been raised. Thank you. I will hand over to Yannick. Yannick, do you have anything to say or
no. You are the lead of the webinar.
You know, you are the man in the background, you know, doing the yeoman job. So if I don't know if Dr. Shant Matri, you have anything to say in your Latin, or Dr. Grace?
I just want to say thank you to Mitri. She did great work, great analysis, and I also picked some points from you. So thank you very much. And thanks to AFRANI, young nephrologists, AFRANI EXCO, the research subcommittee. Thank you, Yannick, for pushing me to do this. And really, thanks to everyone for attending and for your questions. Yeah.
Thank you, Grace. And
Matri,
thank you, Mitri, for your very lovely slides.
Yeah. Mitri is still smiling.
I will share the slides with Letish.
Yeah, Dr. Ukam, you were telling something?
Yeah, it looks as if you have something to say.
No, I'm
Okay,
fine.
all right.
Thanks. Thank
Okay.
you.
All right, okay. So on this note, we just say we want to conclude today's series. And then I want to say good evening, good afternoon, good morning to everyone once again for attending, and have a nice time.
Thank you.
Thank
Have a
you.
good
Thank
night.
you.
Thank you,
Bye.
Tamu, for
you.
Thank you.